It's my great pleasure to welcome Dr. Callie Barrett, who is actually a close friend of mine. We trained together in Toronto a few years ago. She currently works at University Health Network, and she focuses her work on cost effectiveness of critical care programs. She serves on the Ontario Health Technology Advisory Committee at Health Quality Ontario, and as well as advises the Ontario government on recommendations for which treatments to adopt here in our province. Today she's going to speak to us about the economic burden of sepsis as part of Sepsis Canada team number 1. Thank you, Callie.
Thanks, everyone. Lovely to see you, Alex. That was a nice surprise this morning. So yeah, I'm here to talk with you guys about the economics of sepsis. So I have a couple disclosures. I'm going to be talking about a Sepsis Canada funded study that we're doing. I've done some work for a device manufacturer that's not related at all, and I'm an intensivist, so I see a ton of sepsis. So before we get talking about sepsis, I want to talk about this high cost, high user concept that's very sort of prominent in the health decision, health systems leadership world, maybe a little bit less so within the clinical world, but I think as you start to see some of what I'm going to describe, you're going to realize that you're actually seeing a lot of this in your clinical practice. So there's this phenomenon where a very small, there we go. So a very small percentage of the population is actually responsible for a massively disproportionate amount of healthcare costs. So a study from Ontario published in 2014 showed that the top 1% consumed about 27% of healthcare dollars. And when you looked at the top 5%, they consumed over 50% of the dollars. And then a more recent study, again in Ontario, in 2017, the top 5% of healthcare users incurred over $20 billion, which was responsible for over 66% of total healthcare costs. So clearly it's a big problem, and this phenomenon is seen in all jurisdictions, including low and middle income countries. The Commonwealth Fund in the United States, they've done a lot of work into this. They use a lot of Medicare data to do these analysis, and they've defined high-cost users a little bit differently. They've defined it as individuals with 3 or more chronic diseases with functional limitations, which as clinicians in the room, that's a very important point. And the takeaway here is that the top 1%, like that is a very high amount. And then when you compare it to the amount in sort of the median spending at the population level, like orders of magnitude different. So that is sort of the amount, the impact on total overall health budgets. The other important feature is that when people are high-cost users, they tend to remain high-cost users. So in this group with 3 or more chronic diseases with functional limitations, in the US data at least, 30% are high-cost users for 2 years in a row, and another 32% for at least the next year. So it's a durable effect, unfortunately. So there have been more recently, health systems and health system leaders have been interested in, what makes someone become a new high-cost user. And some of the sort of predictors that have come up are older age. I actually found a study this morning that was talking about it being female actually as a risk factor. So male in some areas, females in others. Rurality is a very strong predictor, especially here in Ontario. Previous healthcare resource utilization. So this is a bit of a no-brainer. If you've been sick before and it's a chronic condition, you're going to remain sort of chronically unwell and continue to consume healthcare dollars. But then there's these issues of sort of new, either incident diagnoses of problems, but acute inpatient care for new incident disease, congestive heart failure, COPD, diabetes. That should be no surprise to the clinicians in the room. Pregnancy disorders, childbirth, postpartum sort of issues. So women can transiently become a high-cost user as a result of complications of childbirth. And then children born with congenital disorders obviously consume a lot of high healthcare costs. The most sort of disappointing thing to read here in Ontario and in Canada is that food insecurity, here we are, we're a high-income country, food insecurity, a key social determinant of health, this is just another example, is a huge predictor of future healthcare resource utilization. So once again, it speaks to the importance of those social determinants of health that exist at a community level, at a marginalization level, highly important. So why do policymakers care about this? Because it sort of speaks in language that they understand. They know that if they think they can target their funding, they can target their interventions into this really small populations, it could result theoretically in pretty large, significant savings to the healthcare budget. And as a health economist, also improve well-being at the population level, right? So then now let's think about sepsis. Okay, so the clinical burden of sepsis, in this room we all know this, it's high, it's got a very high mortality rate. It's also associated with lots of morbidity after the incident episode. Decreased health-related quality of life, functional decline, cognitive decline, mood disorders, increased risk of cardiovascular disease. That one's hot off the press and partially funded by Sepsis Canada, worsening of pre-existing health conditions. All of this morbidity leads to healthcare resource utilization. So readmission to hospital after sepsis is high. 20% at 30 days in one study, over 50% at 6 months in another, over 66% by 5 years in a study I'm going to show you in a second. And the additional healthcare resource utilization consumed or used by sepsis survivors is higher than other individuals who are hospitalized for non-sepsis conditions. So it's like the sepsis survivors kind of get off worse. And this is all highly resource intensive and expensive for our publicly funded healthcare system. So I've been thinking for a while, does sepsis create high cost users? And I first learned about this concept of high cost users when I went to the London School of Economics and did my master's, and one of my health financing professors just kept really emphasizing this point. And the top 1% in Canada, and this is I think a 2014 analysis, the top 1%, their average healthcare costs were $53,000 a year. The top 5%, their average costs were about $13,000 a year. Pretty high. Then I was doing more work, and I looked at Margaret Heritage's 5-year outcomes after ARDS work, and was using her costing data to inform a model that I was developing, and went, oh my gosh, the ARDS cohort at 1 year kind of fits in this high-cost user category, and their healthcare costs in year 2 and year 3, are well above the bottom 50%. So they continue to use healthcare resources. So ARDS survivors appear to be high-cost users. So recently published paper, this is required reading for anyone interested in sepsis economics in Canada. So this is Kidnappa Favorn and her master's student did this excellent paper. It was based out of ICS using health administrative databases there. They similarly showed that sepsis survivors compared to people who were, patients who had sepsis compared to patients who were also hospitalized but didn't have sepsis had increased mortality, more pronounced in the severe sepsis category. They also had increased healthcare resource utilization, and 62% of them, sorry, it's hard to see from here, 62% of them at up to 5 years were readmitted, a little bit lower in the non-severe sepsis cohort, but significantly higher compared to the match controls. When she calculated their overall healthcare costs over time, the mean cost for the cohorts was year 1, $66,000. So those are high cost users. When you get to year 5, $28,000. That's fully within the top 10%. So what they've demonstrated, at least at sort of the average population level with respect to sepsis over this time period, was sepsis survivors who, granted, and this is a limitation of my sort of interpretation of this, is that granted, yes, their healthcare costs in the previous year were high, so this was not a healthy population to begin with, but their overall healthcare costs were high for the next 5 years. So this was a durable effect as a result of sepsis. And then they estimated the incremental healthcare costs as a result of sepsis for the Ontario healthcare system to be about $1 billion, which was about 1.6%. Now this is incremental cost. This is not total cost. This is the extra cost that was those hospitalizations from sepsis added to the healthcare budget as compared to the hospitalizations for the match cohort. So I'm going to tell you a little bit about the study that we're doing. And if this conference had been 3 months later, we would have had results to show you, but we're almost there. So our Sepsis Canada-funded study, our overall aim is to determine the impact of sepsis on becoming a new high-cost user. Our first objective is to sort of estimate the individual and hospital level characteristics that are associated with being a new high-cost user at the population level. Objective 2 and Objective 3 are very similar. We're going to look at the impact of sepsis on becoming a new high-cost user compared to the general population first, and then those who are hospitalized for non-sepsis conditions, similar to the analysis that you saw previously. And then, because I couldn't help myself, Objective 4 is to look at whether or not an admission to critical care, yes or no, results in becoming a new high-cost user. These studies are being done at ICS. They are a population-level prospective observation study. We're using IPTW-weighted cohorts, so I want to talk to you a little bit now about how we're going to assign a high-cost user. So let's say we have 2 individuals in our data set. Let's say Laura is 32, female, healthy. Her previous healthcare costs were $800. Let's say Roxanne, 32, healthy. Her total healthcare costs $750. All right, so Laura gets strep throat, Roxanne has an ankle fracture, but oh dear, Roxanne has group A strep bacteremia, ARDS, renal replacement therapy, severe ICU-acquired neuromyopathy, and Laura got her COVID vaccine. Roxanne, as a result of her sepsis episode, now had to go to rehab for several months, has nephrology follow-up because she's recovering from being on dialysis, respirology follow-up, and probably mental health follow-up from her severe PTSD and depression from being in the ICU for so long. Okay, so we know what their healthcare resource utilization was, and we know what their costs are. We get both of these data points from the health administrative databases at ICS. So then what we do is we needed to determine what are the cost thresholds over a given period. So we ran the get cost macro, which gives us the cost for the entire Ontario population in 30-day periods, ranked individuals according to their total costs, and then determined at the top 1% what was their dollar value, at the top 5% what was their dollar value. And so for every 30-day period, we actually know what dollar value of spending gets you into the top 1%. And so then we can then look at our individual's healthcare spending and compare it to these thresholds and assign being a high-cost user. So if we go back down here, Roxanne is a high-cost user because her total costs for 2022 were $55,000. So we're doing this for every individual in our cohort for about 14 million people. In terms of the flow diagram, so this is the overall analysis where we're just sort of trying to get some descriptive data, sort of looking at who are the people, what are the types of hospitalizations, and also the trajectories over time. This is paper 2, this is paper 3, so very different, similar cohorts in that it's this hospitalized cohort, and then the difference is who's the comparator group, so this is going to be the weighted general population cohort, and then this one is a weighted non-sepsis hospitalized cohort. And then very similar sort of analysis here for the ICU cohort. Our study progress right now is we have our cohorts complete. We've determined the high cost thresholds for the entire study period. And we're going to have our results in the next 2 to 3 months, I would say. And then we're planning to repeat this analysis in Alberta. But we wanted to make sure we had our sort of data set creation form and everything sorted out here at ICS. But we're making really great progress. What are we going to learn from this study? It's going to be the first study to estimate the impact of an incident hospitalization on becoming a new high-cost user. We're going to clearly quantify the effects of an incident episode of sepsis on becoming a new high-cost user and how long they remain high-cost users, so those trajectories. And we're going to identify predictors of becoming a new high-cost user after sepsis and as well critical care. So how might this study influence healthcare delivery and health policy? So we're going to demonstrate the economic consequences of sepsis using a metric that health system decision makers understand. We're going to identify the specific hospitalizations and individual level characteristics that predispose people, which we can then use to inform planning and policy and like intervention programs to try to prevent people from becoming a new high-cost user or even developing sepsis. Targeted interventions that might have the most bang for your buck, so to speak. It also, I'm hoping, could inform the development of funding models and care pathways. Like maybe we could get a a QBP for sepsis or for post-critical illness. And so it could help inform funding the care pathway for those patients. And then I'm hoping it will also inform future analyses that really sort of explain this a little bit better. We have a great study team. I'd like to say thank you to Sepsis Canada for funding a summer student here, emerging scientist at my table there, Victoria. I have a patient partner, we have knowledge users. And yeah, it's been a real pleasure working on this team. And so to the CIHR people in the room, thank you very much. Really appreciate the funding for this project. And I hope it will be of use to decision makers soon. And that's it. Thank you. And there's one at the back too.
I'm going to take chair's discretion. There's some questions at the back. Okay. My first question, Kelly, is how do you deal with people who don't have a health care, are unhoused, and how are they included in this?
So the only way you can be included in this cohort is you have to have an OHIP number. It's all the entries into the health administrative databases are via your OHIP number that are then scrambled. But we still have like 14.8 people.
I think this is really impressive. This is an unbelievable amount of data, so this is really exciting work. Have you done any work in linking databases? And if so, how have you been able to overcome the tremendous obstacles that come with linking databases?
So this is a real plug for ICS. So the data sets are already linked. I didn't have to do any linkages. You can bring new data sets into ICS. I have not gone through that process yet, but I'm in the process of sort of negotiating or starting to talk about one. I hear it's not a quick process. And I know that the linkage to the critical care information system has been a bit of a gong show, so to speak. So I think it depends on who owns the data set and how willing they are to work quickly. Alan?
Thanks, Kelly. 30 years ago, data started coming out showing that decedents use a very disproportionate amount of medical resources. And the ability to predict them was good at the population level and terrible at the individual level. As a result, basically nothing got done with that information because it was proved impossible to use it at the individual level. And although, as you pointed out, there could be some policy implications of this, even at the population level, most of the stuff that gets done is at the individual level. So I guess I have some concerns, not that it's not important, but that finding that there's a subgroup of people who are very expensive is not the same as being able to turn that into individual level prediction and therefore more immediate kinds of implications for not so much policy, but for interventions. Any thoughts about that?
Yeah, so it's a well sort of now observed trend that healthcare costs do increase right before death. And we actually do joint point analyses to determine the inflection point so that we can analyze costs separately from that before death phase. We're not doing that in this study, but we are following people till death, so we are going to observe that. And yeah, we expect that we'll see people who were perhaps not high-cost users before become high-cost users before death. Those aren't the people I am actually really interested in with this study. I'm interested in the people who were not high-cost users, who as a result of their episode of sepsis became high-cost users and then continued to live with new chronic conditions and functional limitations, who as a result of that were high-cost users. And then it's by looking for patterns to see who those types of people are. The goal would be to actually prevent them becoming a high-cost user. So maybe those are the patients that in hospital you're really focusing on early mobilization or whatever it shows, or maybe it's ensuring that those are the people that have a really good post-hospital follow-up clinic because they're the ones that otherwise keep bouncing back to the emerge because they're not doing well in the community. So sort of that's where I'm going with it, but I agree with you. I struggle with this a lot at the bedside when we're doing very invasive things and very expensive things to people who I'm certain will die. But it's really hard to think like an economist at the bedside. And I really try not to, because I don't think that's fair to the individual patient in front of me. But, you know, we are supposed to be stewards of the healthcare system, and so at a policy level, at a population level, I'm hoping that we can use this data to help sort of guide decision-making in a way that's palatable to patients and their families.
Hi, great talk, Ryan Perry. I'm CIHR, Institute of Circulatory and Respiratory Health. I'm just curious with, identifying the high-cost user and what the resources are going in. Is there an opportunity with this type of study is to look at patterns of service use to see, is there an opportunity to develop a model of care for effective use of healthcare dollars, right? To follow that pattern, because despite the chronic condition, there are patterns there, and I think there's probably an opportunity to revisit our care models that are disease-specific versus resource use specific, and perhaps there might be an opportunity to think about not the high-cost user, but are there better ways to deliver this service to those that need it?
Yeah, absolutely. And that's why one of the data points that we're collecting as well is emergency room visits and readmissions to hospital and home care use. So that it's not part of our analysis now, but it certainly could be something that we could do later with this data.
The other thing in all of this is there's a reason I put a geographer on team one, is so that we can map some of this across the country, right? So we can map it in Ontario. When we get the Alberta, we'll be able to map it to confirm whether this is socioeconomic status, certain areas in the, city, inner city, is this rural? There are reasons there's a geographer on that team to be able to map some of this out.
Callie, I just have a question for you, more of an ethical question. How do you account for age in this analysis? Because one would assume that age is, potentially a difficult thing to adjust for when you're thinking about a 32-year-old who might have 60 years of healthcare to look forward to, and the health burden of that person's, improvement or survival in the ICU. How does that get factored into the decisions about the high-cost usage?
We're not making any decisions about the high-cost user yet, right? And that's why we need to do some of these data analyses. But yes, age is a predictor of becoming a high-cost user. I think a very interesting sort of subgroup analysis of these data will be the analyses of the younger individuals. The concept, though, of sort of resource allocation based on age, I'm not getting into that. No thanks. Yeah, that's. I don't want to end up on the front page of the Globe or the National Post. Okay, thank you.